so grateful and honored to be here at your first pediatric symposium. Admittedly, I need very little excuse to come out to California if I have the opportunity, and as you will see from my remarks, we are particularly indebted to California for really giving us the idea of taking the Help Me Grow model and thinking about how we can disseminate it across the country. But I'm getting a little bit ahead of myself, but I will make that point shortly. So I am really, really pleased to be here. And also, I should begin by acknowledging that over the many years that I've been involved in academic pediatrics, and I've had a variety of opportunities to speak, I've introduced countless speakers, I'm no longer so enamored with the typical approach to quote-unquote lecturing. I mean, normally, speakers will quote a lot of data, a lot of research, both of which are critically important in trying to emphasize and validate the points that they are making. And I've, over the years, become less and less convinced that that's the way to win over hearts and minds. And I've been more prone to lean towards storytelling. And as I've had the opportunity to speak, even in august academic institutions, I've always felt the need to justify the approach that I am taking. And then I came across this quote from a preeminent cognitive neuroscientist by the name of Roger Schenck, a Professor Emeritus from Northwestern. And here's the quote: "Humans are not ideally set up to understand logic. They are ideally set up to understand stories." So now I feel perfectly justified in taking this approach with you and can point to a preeminent cognitive neuroscientist as the justification. So I often acknowledge that my career over more decades than I would care to admit, but Wendy gave me away, as the relentless pursuit of the answer to the following question: how do we best strengthen child health services to promote children's optimal health, development, and well-being? And long ago, when my colleagues and I first began to try to answer this question, it was logical for us to look at the content of child health services. After all, I was trained as a pediatrician. And when I'm speaking of child health services here, I'm particularly speaking of what we refer to as child health supervision, or what you know as well-child visits, preventive care. So we began by looking at the content of that care, which frankly has not changed very much since the middle part of the last century. The specifics have evolved, but the general activities are the same. And when we looked at these activities, we thought there were two opportunities at the least to strengthen content to promote the outcomes that we are seeking. Specifically, we were interested in the developmentally oriented counseling that we provide during well-child care, so-called anticipatory guidance. And we were interested in the way in which we identify children who have developmental or behavioral challenges and or delays, referred to as developmental and behavioral monitoring. So we began our work by looking at anticipatory guidance, developmentally oriented counseling, and asking the question, what if we strengthen the developmental content in our counseling by educating parents on the importance of various developmental themes at different ages? So for example, at the 2-week visit, we typically will speak with parents about such issues as sleep patterns, elimination patterns, feeding patterns. And we wondered whether if we engaged parents in discussions of such developmental themes as the predictable unpredictability of so-called state organization, the extent to which children's personality or behavioral style, their temperament, is obvious very, very early in life, in some instances, even in the prenatal period when a fetus is very active. And that has implications for an infant's behavior. Or the importance of attachment to discourage needless parental fears of spoiling. Would these developmental themes make a difference in outcomes for parents in terms of their parenting behaviors, and most importantly, for infants and children in terms of their developmental and behavioral gains? And lo and behold, after a very well-designed study, we found absolutely no difference between the intervention group and the control group. We were hesitated to publish the study, even though we were confident in its methodology, because we worried that the takeaway would be anticipatory guidance isn't worthwhile. That wasn't the takeaway. That's not what we studied. So we ultimately did publish the article, and we published it with presenting the following implications. Number one, that anticipatory guidance should certainly be continued to be employed as a strategy to strengthen parents' capacity to promote their children's optimal health, development, and well-being. But rather than use a long list of content that we, in our expertise, decide that is what parents need, instead, we needed to individualize the content and discuss matters at the level of parents' cultural, cognitive, and psychological readiness. And in fact, the best approach might be an open-ended agenda driven by parents' priorities. That was way, way back, almost 5 decades ago. Fast forward, we will talk about this work that we are doing today in a process called goal concordant care, but that's getting very ahead of myself, but we will get there. So having conquered developmental counseling or anticipatory guidance, we then shifted our attention to developmental and behavioral monitoring. Anyone want to guess the country within which this photo was taken? Formal garden help? England, it is. It's the United Kingdom. Specifically, it's Oxford. And I had the opportunity to take sabbatical at the University of Oxford and study the approaches to developmental and behavioral monitoring we take in the United States and compare our approaches to those taken in most developed nations. We have placed a disproportionate emphasis on screening as the strategy for early detection. And screening is important, by the way, but we have tended to emphasize screening in isolation, very, very different than what is done in other countries. So, by the way, when I was in Oxford, I know the number of home visitors we have in the room. We also became engaged in working with, in England, home visitors are called health visitors, and had the opportunity to make a number of home visits and actually do a study. My wife was a certified health educator, and I did a study looking at the value to families of health educators coming into the home. And no surprise, it was found to be very, very valuable, and it shaped my views on home visiting to the present day. So what we specifically did with regard to developmental and behavioral monitoring and developmental screening was look at the criteria by which the conditions for which we are screening adhere to well-established attributes that define conditions that are particularly amenable and appropriate for the screening process. So if we're talking about developmental delays, think about children with speech and language delay or behavioral issues, how well do those conditions fit the criteria by which conditions are judged amenable to the screening process? And the bottom line is that they fit, but not all that well. They have to, for example, have significant morbidity, not mortality, but significant morbidity. Screening must involve the entire population. We must be able to distinguish affected from non-affected persons. Early detection and intervention must make a difference. It must be available, etc. Developmental and behavioral conditions fulfill those criteria, but not ideally. Secondly, we looked at the extent to which developmental and behavioral screening tools fulfilled the criteria by which tools are judged psychometrically sound for the screening early detection process. And again, there's a fit, but it's not ideal. Screening tools need to be simple, they need to be convenient, they need to be accessible, they need to be reliable, they need to be economical, and they need to lend themselves to early, easy interpretation. Not a great fit. Good, but not great. And then perhaps most importantly in our research, we also recognized that screening tools often do not incorporate the most helpful information available when it comes to early detection, and that is parents' opinions and concerns. If a parent has concerns about their child's development or behavior, there is likely to be underlying issues. And most screening tests do not capture those concerns. So on the basis of this, we advocated for a comprehensive, integrated process that was called developmental surveillance and screening. And surveillance was used because it's a European term that was used in the context of child health services. Child health surveillance and screening incorporates, number one, eliciting and attending to parents' opinions and concerns, as well as a variety of other activities that we do on a routine and regular basis, obtaining a relevant developmental history, making observations of children, identifying risk and resiliency factors. When concerns arise, soliciting input from others who know the child and family, home visitors, early care and education providers, Head Start teachers, etc. And periodically administering screening tools to ensure that children do not slip through the cracks. But when screening tools are administered, the results are never interpreted in isolation. It's not just adding up a score, but rather interpreting the results of screening in the context of all that's known about the child and the family. Surveillance and screening. And while it was a bit of an uphill battle, and while it did take a number of years, bordering on decades, ultimately surveillance and screening has become the official policy of the American Academy of Pediatrics and best practice as defined in its clinical guidelines. We'll come back to this term surveillance, which these days has a bit of an onerous feel, and justify why the approach is now being renamed family-engaged developmental monitoring, but I'll reference that a little bit later. Okay, so now we've conquered anticipatory guidance and developmental and behavioral monitoring. What's next? Well, we and others realized that if all we are doing is detecting, but we're not intervening, that's not going to be very impactful. And in fact, our developmental and behavioral pediatrics colleague, Ellen Perrin from Massachusetts, said, not only is that ineffective, it also should be judged as unethical. And we agreed with that. So now we are in the 1990s, thinking about how we best identify but also support children who may be at risk for adverse developmental and behavioral outcomes. And the fact that this was in the 1990s, and by the way, I realize I have 45 minutes to speak. The fact that I'm only at the 1990s now, you won't be here all day, I promise. I promise. We'll move quickly. But this was a pivotal period because it was widely recognized as the so-called decade of the brain. in which the explosion in our knowledge of brain development and early child development, which really evolved from the 60s, the 70s, the 80s into the 90s, really came to the fore in the popular press. Here's a cover story from Time magazine on how a child's brain develops, as well as in the professional press. Here's a publication from the prestigious National Academy of Medicine. And these concepts were critically important in informing our thinking. So for example, and no fear, for those of you who haven't taken a biology course since high school, I'm not going to get into any depth here with regard to brain science, but it is important for us to keep in mind that there are critical aspects of brain development that are so prominent and important during the prenatal period and early infancy. The fact that brain growth disproportionately occurs during the prenatal period and the first 2 years of life. The fact that there is neuroplasticity, the ability of one part of the brain to take on a function of another part of the brain that may be damaged due to injury or disease or disorder. And while that's a lifelong function, think about adults being treated for strokes, for example, it is particularly useful during earliest childhood. 3, that there are critical periods of development in which stimuli must be present in order for brain development to proceed normally. Children without the benefit of rich, loving, warm, supportive experiences early in infancy miss the opportunity for subsequent normal brain development and child development. Brain development is sequential. Therefore, experiences need to be sequential. Few infants will benefit from an algebra lesson. Few adolescents need to be held and rocked each day, although we all know a couple of exceptions to that. So sequential brain development, sequential experiences. And then probably most importantly, the role of experience. As we have already said, if infants do not benefit from rich, stimulating, warm, loving experiences, the number of brain cells, neurons, fail to multiply, and the connections between brain cells, so-called synapses, fail to initially be formed and then ultimately fail to be so-called pruned. That is, those connections that we don't need will disappear to achieve efficiency, but only with the appropriate experiences. So keep these concepts in mind as we think about early detection and early intervention. Just as importantly, there are critical concepts in child development that also have a profound influence on the way in which we think about these issues. And one of our colleagues, actually from UCLA, Neil Halfon, who directs the Center for Healthier Children, Families, and Communities there, coined the term developmental trajectories in speaking about children's developmental pathways. And as we all know, there are those children who are progressing along the so-called delayed or disordered trajectory. This is about 12 to 15% of the population. These are the children who actually were my patients when I was doing developmental and behavioral pediatrics. And then, fortunately, there is a majority of children who are progressing along a so-called healthy trajectory, along a quote-unquote normal spectrum, as wide and variable as that may be. It is not an overwhelming majority of children, however, because there's a third subgroup of children for whom we have failed in the past to pay sufficient attention. And these are children whom Halfon described as progressing along an at-risk or a vulnerable trajectory. These are children who can go either way from the standpoint of their developmental progression. With the right circumstances, they can be elevated to a healthy trajectory, or under adverse circumstances, they can deteriorate to a delayed or disordered trajectory. So here, for example, are only 3 of many, many factors that may negatively impact vulnerable children's developmental trajectories. Socioeconomic disparities, lack of access to health services, lack of access to high-quality early care and education programs. Fortunately, as Halfon points out, there are a whole host of factors, and don't worry about the specifics here. You could fill this in very easily. A whole host of factors that are critically important, if present, in elevating children's developmental trajectories. Parent education, particularly during earliest infancy, during the prenatal and early infancy period. Parents' emotional well-being, health literacy, growing up in a protective home environment, having access to a medical home, having access to high-quality early care and education, and growing up and experiencing safe and nurturing neighborhoods. These are just select examples of many. The implications of this concept are critically important, and I can't improve on language that was used long ago. 1992, a pediatrician by the name of Robert Chamberlain, working in Rochester, New York, wrote the following. The most effective long-term strategy appears to be the development of a comprehensive, coordinated, community-wide approach focused on preventing low and medium-risk families from becoming high-risk, as well as, of course, providing intensive services to those who have already reached a high-risk status. 1992. We are still working to catch up to this wisdom. Okay. So with these concepts in mind, we realized that we're not going to get there. That is, we're not going to be able to strengthen families to promote children's optimal health development and well-being by exclusively focusing on child health services. Too narrow a framework. And at the very least, we needed to think about the 3-leaf clover of child health, early care and education, and family support. And when I say family support, home visiting is really the prototype for family support services. So it was with this thinking in this context that we were asked in Hartford to think about what we could do to strengthen supports for families to promote children's optimal health development and well-being. I don't know how many of you have spent any time in Connecticut. If you've traveled in New England and the Northeast, you've probably at least passed through it between New York and Boston. But Connecticut on the whole is a very wealthy state. We are always in the top 5 of states with regard to per capita income, at times number 1 or 2. On the other hand, Hartford, the state capital, is consistently ranked one of the poorest cities in the country. In fact, it's been ranked the 2nd poorest city of its size behind Brownsville, Texas. So we have some challenges and disparities. Hartford has some lovely areas. This is the Soldiers and Sailors Arch in Bushnell Park near the state capitol, but it also has very poor housing stock that poses hazards for children and families. So we had the opportunity, with support from a local foundation, to have a series of critical community conversations with residents and families, with providers from different sectors, with elected officials, with community-based organizations, and we were stunned by how quickly we came to 4 common assumptions. And I invite you to think about these assumptions in the context of the work that you are doing and the communities, neighborhoods within which you are working. Number 1, we assumed that children with developmental and behavioral issues were escaping early detection. Well, any visit to a Hartford classroom would realize we were not exactly out on a limb with this assumption, unfortunately. Number 2, that even in relatively resource-poor Hartford, there existed a wide array of programs and services to support families in promoting children's optimal health development and well-being. But number 3, there was a gap. There was a gap between the best efforts of child health providers, early care and education providers, family support providers in the detection of children, particularly those vulnerable and at risk, and the linkage of those children and their families to community-based programs and services. So our fourth assumption was that Hartford children and families would benefit from a coordinated region-wide system of early detection and referral and linkage intervention for children at developmental and behavioral risk. So on the basis of these four assumptions, and with additional funding from the same local foundation, we decided to do a pilot study of a model that could potentially promote early detection, referral, and linkage. And the four components in that pilot study are still the four core components of the Help Me Grow model today, as you will hear about in much more detail in the next panel discussion. So I'm not going to go into details except to say that these four core components include engaging providers, including child health providers, to make sure they understand the principles of surveillance and screening, and also understand how to best access this model for referral and linkage. Number two, family engagement, to encourage families, parents, to realize the importance of their sharing opinions and concerns, and also understanding a model exists to help link those concerns and their children to programs and services. Three, the heart of Help Me Grow, which is the information and referral system. At the time, it was only operators who were available through an information and referral line. This was prior to the internet becoming so pervasive in its use. But that was the vehicle by which the referral and linkage was done and the resource inventory was maintained. And then number four, because we knew we would need to prove the efficacy of the model in order to sustain it with funding, and because we knew there were gaps and capacity issues in Hartford, and we would need the data in order to reinforce the importance of addressing those gaps and capacity issues, data collection and analysis. Four core components of a pilot study. They continue to be the four core components of the model today. And again, the history here has so far exceeded our wildest expectations. In the early years of the new millennium, we secured state support in Connecticut to bring this Hartford pilot to implementation across the state. A few years later, I actually received a call from a neurologist from Orange County, California, who previously worked in Springfield, Massachusetts. How smart was he going from Springfield to Orange County? But that's another story. Dr. Joe Donnelly, who said, you know, we need Help Me Grow here. Can you help us? And I said I didn't have a clue, but we'd be happy to try. And it was our really first experiment with providing technical assistance. And as you may well be aware, Help Me Grow Orange County is a very, very strong affiliate and has taught us a lot about how to go about the work of providing technical assistance. And so we began to provide technical assistance to more states. We designed and implemented our Help Me Grow National Center, and as you've heard, the story today is over 140 Help Me Grow systems in more than 30 states, and we have 3 or 4 currently new states on the line who are about to join us. And our goal is every state, every jurisdiction across the country. This is what our map looks like now, but fortunately we need to update this very frequently. You'll hear much more about the Help Me Grow model. So we could have rested on our laurels and stopped there, and I would actually be done early, except with the new millennium came an increased appreciation of the so-called biology of adversity. And you're all aware of toxic stress, adverse social drivers of health, adverse childhood experiences. And we recognized that in thinking about promoting children's optimal health, development, and well-being, even our enlightened, broad vision of bringing together child health, early care and education, and family support was much, much too narrow, because 90% of the outcomes that we collectively seek for children, are a function of social and environmental, behavioral, and genetic, really epigenetic factors. And we can't influence these factors by restricting our work to only 3 sectors. So, we began to think much more comprehensively about what are the factors, what are the sectors that we must engage in this coordinated, integrated, system-building approach if we are ultimately going to achieve the best outcomes for children. And we kept adding sectors to our so-called flower diagram. And this is the current version of it. And as you could see, it's a fairly strange-looking flower. And I mentioned that at a talk, I think it was in Washington, D.C., just pre-pandemic. And I said, you know, we probably need to think about a new metaphor, a new analogy. And someone in the audience yelled out, Dahlia. And I live right on the West Hartford border. We have a beautiful park that encompasses both cities called Elizabeth Park with a world-famous rose garden, but it also has a dahlia garden. So I went to Elizabeth Park, and I've looked at the dahlias a million times, and this is a dahlia. It has more petals than we could ever fill, even it being very expansive in terms of thinking about sectors. So we're sticking with flower diagram or dahlia diagram. So how do we operationalize this concept of system building? How do we bring together sectors in a comprehensive, integrated way that can best support families in promoting children's optimal health, development, and well-being? And let me give you a couple of examples. So in our work at Connecticut Children's, we had the opportunity about 12 years ago to form what we called the Office for Community Child Health. And we brought together a variety of community-oriented programs that already existed across the organization, but not in any coordinated, integrated way. And we decided that we needed an infrastructure that would support these programs to A, achieve scale and impact, B, to actually work together because they were often serving the similar or same populations and yet working independently in a siloed fashion, which is a problem for so many of us. And then third, we realized that we also needed to support these programs in identifying new challenges and encouraging potentially innovative approaches to critical contemporary issues. Think the mental health crisis, think childhood obesity. If someone has an idea that may be impactful, how can they pilot test that? And if successful, how can they elevate a pilot test to a sustainable program? So we formed the office to do those 3 things. We began with about a dozen community-oriented programs. We're now up to 17, and we'll continue to add programs as new programs evolve, as new issues demand our attention. So this is how we've operationalized the concept. We're also doing work at the national and the local level that also demonstrate how we build systems in a comprehensive, integrated fashion. We are involved, that is, the Help Me Grow National Center is a primary player in a national initiative called Early Childhood Developmental Health Systems. Some of you affiliated with First Fives and Help Me Grow may be part of these discussions, but we are working with a number of organizations at the national level, including the federal agency, the Maternal and Child Health Bureau, 0 to 3, the Center for the Study of Social Policy, Family Voices, in figuring out how we can bring different sectors together and local jurisdictions to work in a comprehensive, integrated way. And this work is now several years in implementation and is beginning to make some strides. So you will hear more about this. The important point about this is the federal government is increasingly recognizing the importance of system building. And the Maternal and Child Health Bureau has committed dollars to this work and is actively engaged in the work. More to come on this. I want to share with you a local example that we began about 2.5 years ago in North Hartford. So I don't know if some of you may be familiar with an initiative in New York called the Harlem Children's Zone. Anybody? The Harlem Children's Zone is a very, very innovative approach to how to support families, elevate children's developmental trajectories, academic progress, and actually occupational and societal outcomes in a neighborhood or neighborhoods, central Harlem, that have been very, very challenging due to a wide variety of reasons that you are probably quite familiar with. A charismatic leader by the name of Jeffrey Canada decided that enough was enough, and he and residents needed to elevate the status of families and children and students, and designed a model called the Harlem Children's Zone, which has been really a national wonder in terms of its impact. The Obama administration, well aware of Harlem Children's Zone, decided to designate certain impoverished communities across the country as Promise Zone communities, making them eligible, giving them favored status in applying for grants to try to improve living conditions for families and children. That led to an initiative towards the tail end of the Obama administration called Promise Neighborhoods, led by the U.S. Department of Education, in which communities were invited to apply for grants that would enable them to build so-called cradle-to-career pipelines. And we were asked by the leadership of the city of Hartford, by the mayor, to apply on behalf of Hartford. We agreed, not realizing what we were getting ourselves into. And then 2.5 months later, we had a grant proposal that was about 95 pages in narrative, over 600 pages with attachments and appendices, in a very, very competitive grant selection process. In any given grant cycle, there were upwards of 100 to 150 applications with 0 to 6 grantees. The approach that we took is why I want to mention this to you. Most Promise Neighborhoods grantees do community needs assessments, identify the needs of the community, and then propose to take the money, $30 million over 5 years, to build the programs to address those needs. We decided to not take that route because in our conversations with residents, community-based organizations, civic leaders, we realized that the problem in Hartford is that we have a disconnect. We have a disconnect between families who have priorities, opinions, concerns, and needs, and a wide array of community-based programs and services that were ready, willing, and able to support the families, but didn't know where the families were and weren't connected to the families. Even in these underserved areas, there were a variety of programs and services. So what we opted to do was connect the disconnect, and we did it through family navigators, home visitors, care coordinators, and bringing also the care coordinators together so they knew what each other was doing in a comprehensive, integrated fashion. All driven by community voice, community co-production, and now we're almost 2 3/4 years into this work, making considerable progress both in system building and in outcomes. So how do we know any of this work is making a difference? Because if we're talking about promoting children and youth's optimal development, behavior, educational outcomes, occupational outcomes, societal outcomes, that takes years to decades to document. We need to know in real time whether we're on the right path. In addition, we need measures that can help inform our quality improvement activities as we try to refine what we are doing. So in our partnership with the Center for the Study of Social Policy, we opted to embrace the protective factors framework of the Strengthening Families Initiative, because we know that if we can strengthen protective factors, we are ultimately going to achieve the long-term outcomes that we are seeking. To the extent that we are strengthening parental resilience, enhancing family social connections, increasing parents' knowledge of child development and parenting, enabling families to achieve access to concrete support in times of need, and giving families the tools to promote their children's social and emotional competence, ultimately this is going to result in the outcomes that we are seeking. We do this, that is, external evaluators have done this for us with the Help Me Grow model, and we're similarly using it in our Promise Neighborhoods work to determine the extent to which families believe protective factors are strengthened, and the results are overwhelmingly positive. So we know we're on the right track, but the right outcomes are not necessarily sufficient to convince policymakers, foundations, funders to make investments in this work, because ultimately it's all about the dollar, right? It's the financing that drives anything. So we need to be able to fight fire with fire and speak to the extent to which this work, the work that you are doing, the work that we are doing, the work that I've described, has a return on investment and results in cost savings and cost benefit. And in fact, it does. So what we have now done through the Help Me Grow National Center, working with a group called Manat Health, is develop a return on investment calculator. And we know, to the extent that we are creating diversion, that is, children are not undergoing unnecessary developmental assessments, but rather are receiving supports for their level of developmental concern, the extent to which children are appropriately referred on to early detection and IDEA Part B, Part C, etc., the extent to which families are being referred to home visiting programs, to positive parenting programs, the extent to which families receive benefits for food and address food insufficiency, the extent to which screening for postpartum depression is being performed, the extent to which children are referred on for early preventive dental care. All of these activities have a return on investment, and we can calculate it. So we have found that putting together this return on investment calculator has enabled a number of our Help Me Grow systems across a number of states to calculate the actual savings they are accruing to the state or to the county by implementing the Help Me Grow model. And the numbers are pretty staggering. So across our Help Me Grow experience, for every dollar invested in the model, the returns are $15 to $29 in quantifiable savings. That's enough to convince legislators that this is worthy of their attention. Okay, so let me spend the final couple of minutes talking about where we go from here. And you're going to hear more about these activities in the panel discussion, so I'm not going to go into any detail. You remember way back when we talked about our work with anticipatory guidance and the importance of an open-ended, parent-led agenda rather than one driven by our benevolent knowledge and expertise. We are now working to bring this model to bear in a number of Help Me Grow systems around the country and in a number of healthcare systems. It's called Goal Concordant Care. You'll hear more about that. But ultimately, we believe that by focusing on parent-identified goals and concerns, we will have a much higher level of family engagement, family satisfaction, and ultimately better outcomes for children. Secondly, we talked about surveillance and screening, which is still best practice, official policy. And as I mentioned, the term surveillance has fallen into disfavor. So a preferred terminology, as agreed upon by the Centers for Disease Control and the Association of University Centers on Disabilities, AUCD, is Family Engaged Developmental Monitoring. But it's the same concepts that we've already talked about, and this is now being promoted as best practice across the country. And then third, we recognize that we are primarily concerned with those children who are vulnerable and at risk due to socioeconomic, behavioral, and other factors. But if we want elected officials to invest in our models, they must have universal application. So when I was advocating in the late 90s for statewide spread of Help Me Grow in Connecticut, there was no problem when I was speaking with representatives from the urban core neighborhoods, but I needed to be able to speak to the relevance of Help Me Grow when I was speaking with legislators who, for example, were representing Greenwich, Connecticut, probably the richest town in the country. Universal is important. All families need guidance and support, regardless of their socioeconomic status, but those with the greatest need must have facilitated access. And that's exactly what targeted universalism is. So how did we make sure this was the case? Well, when Help Me Grow was externally evaluated, in Connecticut, every 3 years, there was a triennial evaluation. The evaluators looked at the extent to which certain communities were disproportionately served and consistently found that those in the urban periphery and urban core were taking advantage of Help Me Grow to a much greater degree than their percentage of the overall population of the state. Targeted universalism. Okay. So let me end talking about the importance of affiliation. And I noted here in Santa Barbara County, you have an extraordinary array of organizations working together. That's really, really impressive and important. So here's a slide that shows program partners with whom we are working across the country. And these are agencies and organizations with whom we are working across the country. How do we do this? It's all based on trust and the importance of relationships. And to emphasize this, I want to offer you 3 quotes. The first from the business and author guru, Stephen Covey. You've probably heard the phrase, "These things move at the speed of trust." It's so true. I mentioned Jeff Canada, who's the founder of the Harlem Children's Zone, and he advised us when we were doing our work in North Hartford that efforts such as the North Hartford Ascend Pipeline must successfully build trust by engaging the community and its residents as authentic, valued, and influential partners. This is so true, and we have done exactly this. And then more recently, I heard a quote from Reverend Jennifer Bailey of the Faith Matters Network. Relationships are built at the speed of trust, and social change happens at the speed of relationships. So bringing you all together to enable a strengthening of relationships across diverse programs and agencies and organizations. It's critically important in system building. So let me end where we began. That is, I told you that the work that we've done over a long period of time has been driven by the relentless pursuit of the answer to the following question. How do we best transform child health services to promote children's optimal health development and well-being? More recently, we've come to appreciate this isn't really the right question. Here's the question driving our work today. How do we best build comprehensive early childhood systems to strengthen families to promote children's optimal health development and well-being? This is the work that we are all doing. We know the answers to this question. The knowledge is not the issue. The real question is, do we have the will? I know that all of you in this room do, and to the extent that we can engage others and encourage them to have the will, we will be successful. So thank you very much for your attention.